motivated to learn and educate others throughout the pandemic's quarantine. She is a contributing author in the treatment and management section of the larger COVID-19 resource document coming soon to the Canvas site, and she is our presenter today. Take it away, Zerin.
Thank you so much, Shelley. Thank you for all being here. So I'm going to just go right into my presentation. Okay. So the first article that I'll be talking about looks into the impact of prone positioning in patients who are awake and not intubated, as well as those who've been diagnosed with COVID-19. So there has been literature done on the benefits of prone positioning, but this project looks specifically in COVID-19 patients. So I just want to do a brief overview of why prone positioning is better. So these are two different CT scans of lungs in supine versus prone, and the red arrows are pointing to the dorsal or the back of the lung. So if you're looking into the supine position, the dorsal lung right here, which contains the most alveoli in the lung, which are basically air sacs that are responsible for gas exchange, allowing for oxygen to travel from the lungs to the blood. So that is why we're looking at the dorsal lung, because that's where the most alveoli is present. So if you're looking at the supine position, all that grayness, that haziness, that's all inflammation and edema flowing to the back of the lung because of gravity, collapsing the alveoli, reducing gas exchange, and which then exacerbates respiratory failure. But if you're looking at the prone position, here we're looking at the dorsal or the back of the lung, there's more blackness and less grayness or less haziness, showing that the alveoli are not as collapsed anymore and are able to allow for gas exchange. And because of gravity, all that inflammation and edema are traveling to the anterior front of the lungs. Okay, so before we talk about this study, I wanted to talk about this really well-known randomized control trial that was done in 2013 and published in the New England Journal of Medicine. It's called the PROSERVA trial. And it looked to see the impact of prone positioning in acute respiratory distress patients. And it found that those who were in prone position had a higher survival rate than those in the supine position. And that was found to be statistically significant. They looked at both the 28-day mortality rate and a 90-day mortality rate. And for both rates, people in the prone position had a lower risk of death compared to the supine. So going back to the article that I'm presenting. So this article looked at 88 COVID-19 patients that were admitted to this single hospital in France. And among those COVID-19 patients, 25 were eligible for the study. These patients required oxygen supplementation, and also looking at their CT scans, they had posterior lesions in their lungs suggesting COVID-19. And from these 25 eligible patients, 24 agreed to participate, and that was our sample size. Patients who had to be intubated were not included, as well as those who had impaired consciousness. So what are the outcomes that we looked at for this study? So the primary outcome was responders. So just to define what were the responders in this study, they were participants or patients who showed an increase of at least 20% in their arterial oxygen level during the time period between before prone positioning and during prone positioning. So just to kind of give an idea of what partial pressure of arterial oxygen was, which was the main variable that was looked at. Again, it measures the amount of oxygen in the arterial blood, and it reflects how well oxygen is traveling from the alveoli or in the lungs to the arterial blood, and it's usually altered in severe illness such as acute respiratory failure. So the responders showed an increase of 20%, whereas persistent responders were also responders, but they maintained that increase of at least 20% in the arterial oxygen level when they were resupinated. And then we also looked at feasibility. We looked to see how many patients tolerated at least 1 hour of prone positioning versus 2 hours versus 3 hours. And of course, we also looked at the arterial level of the carbon dioxide. Okay, so this is a really nice diagram from the article. So just to show you here, only 15 patients from our sample size of 24 were used to analyze the data, because only 15 out of the 24 patients were able to tolerate prone positioning for at least 3 hours. The others were not able to tolerate it for at least 3 hours. So out of these 15 patients, only 6 people were responders. That was 40% of the sample size. And from these responders, only half were persistent responders. And then about 40% of the patients were non-responders, showing no increase in the oxygen levels. Okay, so just looking at the variation in responders. So before prone positioning, the PaO2 was 73.6. The normal range values for a normal arterial oxygen level is between 70 to 100. So this was on the lower end, 73.6. This was before prone positioning. Whereas during prone positioning, it increased to 94.9 on average, which was closer to 100, which is ideal. Just to let you know that the oxygen level was measured 1 to 2 hours after prone positioning. So the mean difference, 21.3, and was statistically significant among responders. So looking at the level variation in persistent responders. So initially it was 73.6. After resupination, it was 77.8, indicating that initially, during prone positioning, it was 94.9, but after resupination, it decreased to 77.8 on average. However, this was not statistically significant. All right, so just talk about some limitations. Our sample size was small. We started with 24, but then only 15 of our patients tolerated prone positioning for at least 3 hours. Also, the study was observational. It was not a randomized control trial study, which would really help to determine if there truly was a benefit of prone positioning in these patients. Also, this study was only done for a single episode of prone positioning. And the follow-up was short. It was only for 10 days. And the 10-day follow-up, 5 patients required invasive mechanical ventilation, and 4 patients required intubation within 72 hours of that follow-up. And also there was missing data. So there were 3 patients, out of the 15 patients that we analyzed, 3 of them had missing data for resupination, which was definitely a limitation. Okay, just to summarize the main highlights, 63% of our 24 sample size tolerated 3 hours of prone positioning. And from those 15 patients, only 40% showed a 25% increase in the arterial oxygen level. And among those responders, only half of them were persistent responders. Only half of them maintained that increase when they were resupinated. And that's the end of the slides. So do you have any questions or comments or discussion points?
Do we have any questions for student Dr. Kashem? Ms. Boyer.
Thank you for the presentation. This is a topic that I found really intriguing, just to provide treatment without the mechanical intervention, I think is, obviously beneficial to the patient. I was curious if you were able to find any other articles that would have supported, maybe in a larger sample number, that this method is worth trying before things get to the point that mechanical intervention is required.
Right. So there was a study done in the emergency department in New York City recently on COVID-19 patients. Their sample size was 50, so it is bigger than our sample size, but I still think it was pretty small. And though they didn't look at the arterial oxygen level, they did look at oxygen saturation level, and they found that the oxygen saturation level increased by about 20% in patients who went from supine to prone position, and that was statistically significant. Also, there was another study, but that study also had only 15 patients, but they did show improved respiratory rate as well as improved oxygen saturation rate in patients who were prone.
Thank you.
But you're welcome.
Student Dr. Kashem, I believe Dr. Wolf has a question for you.
Okay.
So, hi. I was curious if they did any correlations to anything that may have been associated with that. So, I unfortunately did not read this paper, but I was wondering, if you look at body mass index, for example, I guess this was in France, so they're unlikely to be as obese as we are here, but it crossed my mind that depending upon your body mass index, you might place even more stress on your diaphragm, or your lung capacity by laying on your stomach.
Right. So again, one of the complications of prone positioning is airway occlusion, which I would assume is more likely in an obese patient. So looking at the baseline characteristics of this sample population we're looking at, only 5 patients were considered obese. And in fact, we had more obese patients and patients who were able to tolerate prone positioning than those who didn't, which seems contradicting, but we did have more obese patients being able to tolerate prone positioning in this sample size. But they didn't look into any other associations.
Thanks.
Yeah, it is a little bit counterintuitive, but
yeah.
Anecdotally, I'm hearing from my clinical friends that that's exactly what they do. They roll them over. And 20% of a 20% rise in oxygen saturation is not a small rise. I think it's fairly accepted now that you ought to roll them over.
Definitely. I mean, there are complications with rolling them over, but, again, this was done on people who are non-intubated and awake, and so they were most likely able to roll themselves over. But at the end, it's very cost-effective because it doesn't cost much to do it, and it's also more cost-effective than mechanical ventilation, which is one of the reasons it's so interesting to look at this method, prone positioning.
Ms. Boyer.
Yeah, it made me wonder if people that started to have symptoms at home, if they were struggling with breathing, if this wasn't something that, doing several times a day at home may have kept people from, flooding the emergency rooms, if it was just more common knowledge that all you need to do is roll over. I don't know, just a thought.
Any
Yes,
more
that
questions?
is interesting.
I'm sorry. I didn't mean to talk over you. Go ahead.
You're fine. No, I just want to say that is an interesting point, but I'm not sure if that's a well-known knowledge in the population, if that's a method to try at home, but that would be interesting.
Yeah, I had never heard of this, so that's why I'm assuming the average person has not either. So thanks for sharing, Zerin. This was I found this really informative.
If there are no more questions for this article, we'll move to the second article.
Okay. So this article was a systematic review and meta-analysis of articles that talked about impact of corticosteroid therapy on patients among the 3 different coronaviruses that we have come across in the past few decades. The SARS coronavirus from 2003, the MERS coronavirus from 2011 and the COVID-19 is currently happening. So I just want to talk about acute respiratory distress syndrome. So why it's important is because 40% of patients with severe COVID-19 will develop acute respiratory distress syndrome, which increases their risk of death significantly. And also there's been a lot of studies that looked at the effect of corticosteroids, which is commonly known as prednisone, methylprednisolone, or hydrocortisone, and has shown benefits to improving these patients. So corticosteroids is an anti-inflammatory therapy commonly used to manage asthmatic patients. And so because of its anti-inflammatory effects, there are some promising therapeutic effects of this for acute respiratory distress syndrome. So, okay, and also it is a highly inflammatory state where there's a buildup of fluid and inflammation in the alveoli in the lung sacs, impairing gas exchange. So I wanted to talk about this really recent randomized control trial that was published this year in February at the Lancet Respiratory Medicine article. And it wasn't analyzed in this meta-analysis, but I wanted to bring attention to it because it did look to see the impact of corticosteroid therapy in acute respiratory distress syndrome, and it has been the largest randomized control trial to date. And this study found that patients that were treated with dexamethasone had a lower mortality rate by about 15.3% compared to the control group, and this was statistically significant. Also, they looked to compare ventilator-free days at 28 days, and they showed that patients who were treated with dexamethasone stayed on the ventilator for less days than those in the control group. And that was also statistically significant. And to my knowledge, that was the only RCT data that we have on this topic. So this article, there's very limited data on COVID-19, of course, but there were two observational articles that were done in a single center in Wuhan, China, that I just want to bring up before we talk about the meta-analysis. But this article, this was included in the meta-analysis, and it looked to see the effect of methylprednisolone on COVID-19 patients in Wuhan, China. And again, as you'll see in the graph, that methylprednisolone treated patients had a higher survival rate than those who were not treated. And that was statistically significant. This was the other study that was done on COVID-19 patient in Wuhan, China. And this study, as you look at this graph, it shows that those who were treated with methylprednisolone showed a more rapid improvement in their oxygen saturation compared to those who were not treated. Also, the use of supplemental oxygen therapy, those who were treated with steroid had to use supplemental oxygen therapy for less days compared to those who were not treated, 8.2 days versus 13.5 days. That was also statistically significant. However, I do want to mention that this study is in preprint, so it was not reviewed. It was not peer-reviewed yet. So it was not included in the meta-analysis, but because there's so much limited data on COVID-19, I kind of just wanted to bring this up. Okay, so going back to the meta-analysis, I just want to go over how the studies were included for analysis in this article. So initially, the authors, what they did was they went through databases such as PubMed, Web of Science, Medline, and also two other Chinese databases to search for articles that were related to any of the three coronaviruses, as well as related to corticosteroids, methylprednisolone, hydrocortisone, risk of death, and so on. They found about 8,788 records through database searching, and then they screened and excluded any duplicate research articles. And after screening and excluding duplicate articles, they assessed for eligibility. So just to discuss how they determined these 159 eligible articles, let me just bring your attention here. The inclusion criteria. So they only included studies that were observational or clinical trials. So they did not include case series, case reviews. They also included studies that looked at primary outcomes of virus clearing or death. They also looked at secondary outcomes such as use of mechanical ventilation, ICU admission, or length of hospital stay. They also only included articles that were in English or Chinese. So of the 159 eligible articles, they only included studies that were relevant to their hypothesis, to their study, and they concluded only 11 studies in total. From the 11 studies, 10 studies were observational, and 1 was a randomized control study. And yes, okay. So the first primary outcome we looked at was virus clearing. So for this outcome, they only looked at 2 relevant studies of a total of 81 subjects. And as you can see, no COVID-19 patients were included. So that was a limitation in this outcome. And as you can see, using corticosteroids actually delayed virus clearing. And that was statistically significant. So compared to those, those who were treated with corticosteroids had a higher viral load compared to those in the control group. And yeah, so this study, the Lee 2004, that was the randomized control study done in 2004 in Hong Kong. And they found that patients that were treated with corticosteroid had higher loads of SARS virus in their second or third week of illness, whereas those who were in the control group, they were cleared a lot faster. And the steroid they used was hydrocortisone.
Can I ask a question?
Of course, yes.
Can you surmise as to why that is?
As to why the hydrocortisone would delay the viral clearing?
Yes.
So from my knowledge, corticosteroid has anti-inflammatory effects as well as immunosuppressive. And so perhaps because of the immunosuppressive effects of corticosteroid that can suppress the immune system from clearing the virus. Also, there has been studies done that show that those who are severely ill or those who are critically ill are more likely to receive steroids than those who are not. So that's also another bias. So perhaps because the more critically ill are the ones more likely to get steroids, they're already immunosuppressed. So that could be a reason.
That's my thinking exactly. You're spot on. So steroids are a double-edged sword sometimes, yay?
Yes, that's what I'm getting at too, yeah.
Okay, thank you.
Sure, okay. All right, so looking at mortality. So there were 8 studies that were included, almost 4,000 subjects, and we did have 327 COVID-19 patients included. So if we're looking at the first group right here, the severe only group. So this group, the study found that corticosteroids reduced the risk of mortality. However, that was not statistically significant. So we should be cautious as to how we interpret that result. Also, in those who are non-severe, it showed that corticosteroid did reduce mortality, but that was also not statistically significant. But overall, there was no association between corticosteroid use and mortality. This was not significant data that they found. So this is one of the secondary outcomes they looked at, which was hospital stay length. Again, this outcome did not include any COVID-19 patients. And according to this data, which was statistically significant, it showed that corticosteroid use actually increased hospital stay length. So those who were treated by steroids stayed at hospitals a lot longer than those who did not. The use of mechanical ventilation. This study did include some COVID-19 patients, about almost 2,500 COVID-19 patients. And it shows that those who were treated with corticosteroids were more likely to be on mechanical ventilation than those who were not. But this was not statistically significant. So going back to what we discussed, the use of corticosteroids in severe patients versus non-severe patients. And as you can see, those who are severe are more likely to receive corticosteroids compared to those who are not severe. And this was also significant. So composite endpoint, there were 3 outcomes they looked at when they looked at composite endpoint. This can include death, ICU admission, or mechanical ventilation. The study found that there was no significant association between these composite endpoints and corticosteroid use. And there were 9 studies that were involved. Okay, so just to talk about some limitations, this study included mostly observational studies and only 1 randomized control study. So again, you do need a randomized control study to really show a true cause and effect. But this was only observational. And also, the 3 articles were in Chinese. So I was not able to read up on them and really look to see what biases they may have had or not. There were also publication bias. So if you look at this funnel plot right here, because of this asymmetrical distribution of the studies, in this funnel plot, it goes to show that there were publication bias. As you can see, there were pretty much 3 articles falling outside of the 95% confidence interval. What were the publication bias? It was not included in the study. We don't know. However, again, there were mostly English studies versus Chinese studies. And again, there were more observational studies included. So selection bias, again, 6 out of the 11 articles that were studied here included only SARS from 2003 and MERS virus, not COVID-19 patients. So we did not have as many studies looking at COVID-19 patients. That was also a limitation. So what are the guidelines on corticosteroids in COVID-19? So CDC says that patients who are mechanically ventilated without acute respiratory distress syndrome, they recommend against the use of corticosteroid use. However, those who are mechanically ventilated and they do have ARDS, there are insufficient data to recommend the use for or against corticosteroid use. However, they do say that for refractory shock, those who are in shock, they do recommend low dose corticosteroids versus no corticosteroids at all. The World Health Organization recommends against use for any kind of viral pneumonia. The Society of Critical Care Medicine recommends against the use of corticosteroids in mechanically ventilated patients without acute respiratory distress syndrome, but it does recommend the use of corticosteroids of patients who are experiencing ARDS and over not using any corticosteroids. That was the end of articles. If you have any questions.
Any questions for our speaker? I had one, if I might. How do you reconcile what the WHO recommends versus Society of Critical Care Medicine?
What do I think about it?
Yeah.
So again, the World Health Organization recommends any kind of corticosteroid use for viral pneumonia. But so the Society of Critical Care Medicine, the recommendation is almost similar to the CDC, except that they think there is sufficient data to use corticosteroid with ARDS. I was looking at this YouTube video where a representative of the Society of Critical Care Medicine was giving a talk, and he's saying that based on the very recent RCT trial that was published in 2020, that is one of the reasons why they are choosing to recommend the use of corticosteroids in ARDS because it has some benefits to it.
Let's say you're in the ER or in the ICU. Who do you believe? WHO, or what do you do?
Well, I would maybe start with the low dose. So again, one thing they mentioned was that dexamethasone is a very highly potent type of corticosteroid as opposed to hydrocortisone or methylprednisolone. So I feel like because there are data that goes against or for corticosteroid, I would probably start with a low dose of corticosteroids, maybe one that's not highly potent, to see whether my patient is responding to it or not. So maybe start with a low dose with the less potent corticosteroid and see how they respond to it.
Try it and see if they do okay. Dr. Wolf.
All right. Okay. Finally unmuted there. So I had, I guess, 3 questions for you. Do you think this is due to systemic effects of the steroids, or is this something that you could treat with fluticasone?
With fluticasone?
An inhalable.
Yeah, so an
steroid.
inhaled corticosteroid. So to what extent do you think that this is caused by systemic effects of COVID-19 versus its attack on the pulmonary respiratory epithelium?
So I do think that the systemic effects of like the corticosteroids that are being studied in the studies, they're usually IV. For the most part, they were IV corticosteroids that were studied, and I think that systemic effect could possibly be suppressing the immune system to a higher degree than these patients can handle. So perhaps something that's not as systemic as the inhaled corticosteroid would show some improvement and not too much of the harmful effects.
It was among the things that crossed my mind. The other thing that was interesting to me was when the patients lived longer, was it they lived longer? Or, I mean, they were on steroids, they were in the hospital longer. Is that because they lived?
I'm not sure.
Okay, and I'll get off. I had one final question here for you that I certainly don't know the answer to. But how is the virus cleared? Is it cleared? I mean, neutralizing antibodies and opsonization and stuff like that, or to what extent are CD8, killer cells or natural killer cells or things like that? How does our body actually get rid of it under most circumstances when people do get better from it?
So I think a lot of it is supportive care. I'm not sure exactly what is the immunology behind it, but a lot of these patients, again, we have to consider the fact that they were put on just very standard care treatments. A lot of them were on antibiotics, which doesn't help with viral clearing, but they were antibiotics. Some of them were already on low dose glucocorticoid. Some of them were already on antivirals like ribavirin and lopinavir. And so I think that, so depending on what the standard care was being used in this population, a lot of these patients, if they already have a good immune system, like if they were younger, they were able to clear the virus with the supportive treatment, versus those who are critically ill and their immune system is already damaged, that they're not able to clear the virus.
I would suspect it's both T cell and B cell mediated immunity that clears the virus. Do we have an immunologist in the room? Can anybody comment on how the virus is cleared? I see no one volunteering, so I'm going to move to student Dr. Bates, Stephanie Bates.
Hi, I just had a question. I'm not sure if you had mentioned it. The data that they compiled, did it take into account like pre-existing conditions that would cause immunosuppression in the population other than just reaching the point of illness in this case and that like, over their immune system, let's say?
So like if they already had comorbidities,
Correct. Like diabetes or some sort of immune deficiency that would that corticosteroids would be the final push of their immunosuppression.
Right. So according to the baseline characteristics, most of these critically ill patients, the most common comorbidity is hypertension and diabetes as well. So those are the two most common that I have seen. So, but however, in this, those were not emphasized, nor did we look to see if they were associated with any of the outcomes that we looked at.
Okay, thank you.
Student Dr. Konigsberg, so you have your hand raised? We're not hearing you. You're muted.
Sorry about that. Can you hear me now? Thank you. This is a question going off what Dr. Wolf just asked. So with a patient with ARDS, would they even be able to inhale fluticasone effectively? And if like they only inhaled a small amount, would that still be effective in treating their airways? And that's, if anyone can answer that, I just want to know.
That's a good question.
I'll comment just a little bit. I don't have a good answer for that, but among the things that was amazing to me is, so I don't have asthma, but I do have a prescription for fluticasone because I have what's likely eosinophilic bronchitis, where at various times of the year I can have massive amounts of sputum production. And the fluticasone, I mean, it's likely triggered by eosinophils, and you may remember that steroids knock out the eosinophils. And so so my experience was I ran out of fluticasone, the inhaled, and I thought, well, I'll just, squirt some in my nose, the nasal stuff, squirt it into my nose and get it down there. And let's just say that failed miserably. So
that is hardcore, brother. That is hardcore.
Well, I'm sitting there, I talked last hour about not knowing what the hell I was doing. And so, but I sat there and was, trying to treat myself with it, and it didn't work. So clearly, it's got to be missed in order to get down there. But your point about whether or not, it's actually going to get to where it needs to be. I mean, the beauty of fluticasone relative to your steroids is that fluticasone is immediately destroyed. So it's got low bioavailability, and as opposed to your systemic steroids. So as soon as it's absorbed, it's going to be degraded. And so to the extent that it's the cytokines and the inflammation in your lungs that's triggering all of this stuff, it seemed to me that if you could get it there, and if that was the main site of action, it might be a better choice than a systemic corticosteroid.
Okay, thank you, Dr. Wolf.
Yeah, thank you. Ms. Boyer, you have a question.
Yeah, I saw in the paper that they mentioned the use before or after mechanical ventilation. They weren't able to determine. Do you think that would have made a difference in the ability to treat had they not treated until it got to the severity of already being on mechanical ventilation?
So one of the things that I read was, so corticosteroid use, you don't want to use it too early, but you also don't want to use it too late. The reason you don't want to use it too early is because of its immunosuppressive effect. And in the beginning, the virus is replicating so fast. And so you don't want to suppress your immune system. So you don't want to use it too early. But you also don't want to use it too late because then the lungs become fibrotic and too damaged to recover from. So yes, I do think by the time that they wait till mechanical ventilation when the patient becomes too critical, that would have a different effect than, let's say, you use corticosteroid at an earlier stage.
Thank you.
Any other questions from student doctors for student Dr. Kashem? Okay, I have a question. This one might be interpreted as mean, but I'm a biochemist and a molecular biologist. Dr. Wolf would call me a molecular endocrinologist or something like that. So I want to know how is it that these steroids are immunosuppressive at the molecular level? Why do steroids suppress your immune response? How does that happen? Do you know?
So I know that steroids will cause apoptosis of your lymphocytes. So you do get a lymphopenia, as well as it also causes destruction of your eosinophils, like you mentioned. So with your lymphocytes gone, which are responsible primarily for virus clearing, that can cause immunosuppression.
Okay, so that's at the systemic level.
Okay.
My question is at the molecular level. It's a little bit deeper. And this is the mean part. If you don't know, I'll offer a response. Is that okay?
Yes.
Okay.
Anyone else can answer that question?
It turns out that nuclear receptors, the target of steroids, have a need for certain co-activator histone acetyltransferase proteins. I'm channeling MCM and SFM now. And it turns out AP1, the main inflammatory response, and NF-kappa B transcription factors share co-regulatory proteins. So it's a shift of co-regulators over to nuclear receptors that inhibits the general immune response. So we have just a limiting amount of co-activators in our cells. And if they shift from one family of transcription factors to the other, you inhibit that response. That's the working hypothesis, and it's kind of been borne out. I'm sorry, I didn't mean to bring up first year medical school.
It's always a nice to be there. Thank you.
Naya, I see your hand is up.
Yeah, I was gonna comment on the how they function, but you had answered the question. So I was basically gonna add that they also lead to the transcript. They basically change the structure of the chromatin and then lead to acetylation and then transcription of IL-10 and other anti-inflammatories.
Naya, you're a woman after my own heart. I love your answer. Okay, any more questions for our speaker? Okay, I'm going to throw it to Shelley, Miss Boyer, who's going to now talk about next week's situation.
Well, thank you again, everybody, for coming, and hopefully you can join us next Friday and continue to spread the word with your fellow SDs to come Friday at 1 o'clock. Next week, we have another one of our third-year students that is a contributing author on the resource document for COVID-19. This is student Dr. Una Kim, and she will be presenting on the topic of promising medication trials for the treatment of COVID-19. So please join us next week, and thank you again, Zerin, for the talk. If we could give her a round of applause.
Thank you.
Thank you, everybody. Have a nice weekend.
Thank
Bye,
you.
you guys.